I know.
Hey, this is Sportsslaw with Lomas Brown, the pro.
And Deb Schneider, I'm the prof. And together, we're the pro and the prof.
Hey.
Hey. Welcome to episode 27 of Sportsslaw.
How are you, Deb? How have you been doing? And wow, wait, can I comment? Episode 27. We're climbing. I remember when we started with number 1. Now we're up to 27 now.
I know. And we've had some great people. We've had some great discussions. I think we're really, examining sports and law and politics and, just about everything that affects sports. And I think it's been great.
Yeah, I think everything is crossing too. You're right. Everything seems like it's happening at once. And man, there's a lot of things going on, in the world and people we're losing. So, I mean, Deb, anything exciting happen or anything you want to touch on real fast that caught your eye during the week?
Well, I think the big thing this week is the loss of Ruth Bader Ginsburg. Mm-hmm. That's, what a person, what a life, how much she means to all of us. And, yes. We talk about her as RBG, the notorious RBG, yes, as being for women's rights, but realistically, she was for equal rights.
Yes.
And voting rights. And I think when we look at the things that she did for us, the fact that women can have credit cards, the fact in their own name, the fact that, I mean, all of this, but a lot of it, when we look at sports, she's responsible for a lot of the way Title IX and all of, women are allowed to participate in sports.
Yeah.
That's a big deal. And I think RBG had a lot to do with that. So just I just think that's a huge change in our society now. It's amazing that one person could have so much of an impact.
Yeah. RIP, rest in peace. And empower to RG, because you're right. That's a pioneer, and it was equal rights. She then, yes, it wasn't a particular group she fought for. She fought for everyone, and she was strong too. I mean, just think about it. She battled cancer, and and was still
4 times.
Yeah, and was still on the bench, still doing what she had to do, and refuse to be taken off. So, shout out to her and, to her family. And like I say, like you said, we lost a great one.
We really did. So I think that's really one of the big pieces of news this week. Mm-hmm. Another, and we've been talking about this novel coronavirus. We've been mm-hmm. talking about COVID and how it affects everybody. I think another thing that happened is we've surpassed 200,000 deaths in the United States. 200,000.
Yeah. Can I say this to you? I remember when we got our second case here in the state of Michigan, and yes, I remember that. I remember the second case. And now you're talking 200,000 deaths. I know here in Michigan, we have probably close to 7,000 deaths here in Michigan related to just the novel corona. So yeah, it's amazing how these months there, we talking about March when this thing hit over here good. And now here we are in September, and we're talking 200,000 people have lost their lives to this.
It's amazing. And this has cut across all socioeconomic It has cut across all races. One of the things that's really amazing to me also is the largest increase in the number of cases tends to be the kids under 30.
Yes.
I mean, we talk about it being more of a devastating disease for older folks, but it really is the largest increase is still the kids under 30. Yeah. And today we've got 2 fabulous guests to talk to us about COVID, novel coronavirus. We've got Dr. Anna Durbin, is professor at Johns Hopkins Bloomberg School of Public Health, and Dr. Rodney Rohde, chair professor of clinical laboratory science at Texas State University. Doc R has been with us. This is his
friend of the
time.
Program. Absolutely.
Absolutely. And, quite frankly, this is actually a continuing series that we've been doing on coronavirus and how it affects sports and how it affects all of us, because as we know, sports is such a big part of our society. And I know Anna is a huge sports fan.
Yeah. Go Blue. I have to represent there.
I like it. I like it. She had the props and everything ready, Dr. R.
Yeah.
Yeah.
There you go. There you
Yeah.
go.
So with that, with us showing sports stuff, it's kind of good to see that sports are back in the swing of things right now. It seems to be that, I wouldn't say things are over, but it seems to be the worst of things in the leagues. That they calmed them down. We know the NBA being in the bubble. Of course, now with the NFL, they've broken camp. They've had 2 games now, and these guys are going back to their regular lives after they leave the facility. And we got the playoffs going on in other sports. So again, I guess we'll start off there by asking our distinguished panel. I mean, what do you think? Where do you guys think we are right now with the COVID in sports as it relates to sports right now?
So I can start if you'd like, because I'm new to the program. So I'm gonna go first. I think really that the biggest advancement has been the rapid antigen testing that can be done in high volume at lower cost with results ready in minutes. I think that's a game changer, at least when we look at college football in the Big Ten. I think that really was the game changer. And what's unfortunate is that we don't have that everywhere. We don't have that at hospitals so people can visit loved ones who are hospitalized with disease, but we're getting there, and we're making those tests more available to more people. And we see that on college campuses, where you have University of Illinois, who's testing every single student twice a week with rapid testing, or at least available testing. And what that allows you to do is identify cases very early and isolate people who are positive and do almost immediate contact tracing. So you're identifying cases, particularly, for instance, in the Big Ten, where you're testing every single day, every single player. You identify people really before they're contagious, and that's really key. So I think, the rapid testing is really a game changer.
That's huge. Huge.
Yeah.
Doc R, what do you think?
Yeah, I agree. I agree with Dr. Durbin. I mean, rapid testing is certainly, testing in general is a key piece to a national strategy. And I still think we're struggling for the national strategy when it comes to testing. Dr. Durbin may or may not know, but that's my kind of area, is medical laboratory testing. So, and I'm a virologist by trade. So it's been frustrating, as you guys know, for me to sit and watch really each state kind of do their own thing along the way. So it's been frustrating as a longtime public health professional and a medical lab tester. However, those rapid tests are definitely going to make a difference, I think, with respect to whether you're asymptomatic or you're looking at people pre-symptomatic, so that you can immediately contact trace. And what the other good doctor probably would agree with me is even the contact tracing for the general public to understand that how critically important that is. And we're working here in Texas to bring on several hundred more just for our university system, because when you start thinking about primary and secondary and tertiary people involved, it's not a phone call. It's multiple interactions with patients and people you're worried about. And here in Texas, I heard Lomas mention in Michigan, y'all hit, I think, 7,000 or so cases. We're pushing 14,000 now.
Yeah.
So we're cooking down here in Texas. And, that testing and contact tracing will be critical. And then as we enter the fall, of course, I had the honor and privilege today to hear Dr. Fauci speak at a town hall meeting. And he brought up, vaccines again. And he's optimistic, cautiously optimistic, but the world of first getting the vaccine and knowing that it's effective, and then getting people to accept it. It's really a synergy there that has to happen. And I know you guys know how passionate I am about vaccination. So I hope we're turning a corner as we approach 2021 and can make some gains in the spring.
Well, I think that's one of the reasons that we asked Anna, Dr. Durbin, to be on this, because Anna, that's your area of expertise.
Yeah.
I mean, you are working on Project Warp Speed.
Yep.
You
and I
tell
want to
us
thank
a little
you
bit
all.
about it.
Yeah, I want to thank you all. This is your tax dollars at work, and I think for a very, very good cause. So Project Warp Speed is really an unprecedented effort. I have to say, this has never been done before. So when we talk about vaccine development, from an idea to preclinical, through clinical studies, to licensure, to distribution, the general timeline is 10 to 20 years for a new vaccine. And what we're seeing here is this pathogen was identified, was first sequenced, meaning we knew what its genetic code was in January. And we had a vaccine in clinical trial in March. That had never, ever been done before. And now what we're doing, when we talk about vaccine development, I think the first thing that's really important to understand that's different about vaccines, for instance, compared with therapeutics, is we're giving something to a perfectly healthy individual. And what that means is safety is paramount. We have to make sure that these vaccines are absolutely safe. And people are concerned when they hear Project Warp Speed because they think we may be cutting corners around safety and not doing all of the evaluations that we normally do. And what I'm here to tell you is that that is absolutely not the case. So where are we shortening that timeline in terms of vaccine development? We're doing it really in a couple of places. The major reduction in the timeline is that we have manufacturers, the federal government has purchased millions, hundreds of millions of doses of each of these vaccines from these manufacturers before we even know if they're going to work, so that they take the financial risk away from the manufacturer. The manufacturer will start, and they all are starting to make doses of vaccine back in June, before they even had any safety or efficacy data. And that is at normally we would call that a financial risk, but the federal government has said we're going to guarantee doses of vaccine that we're going to purchase so that you don't have to worry about that risk. The other thing that we're doing is we're laying the different phases of a clinical trial on top of one another. So we generally start with very small numbers of people in what we call a phase 1, and these are generally young, healthy people, and we're just looking for two things really. Is there any safety signal that we would see that would make us stop right there? And two, do the vaccines induce an immune response? Do we get generally antibodies? Just for simplicity's sake, I'll talk about, does the vaccine do you make antibodies against the vaccine? If yes, then we move on to phase 2, which is generally studying the vaccine in hundreds to thousands of people. Well, we're starting phase 2 before we have all of the phase 1 results. And before we finish phase 2, we're essentially looking at safety in those individuals first. And so if we don't see a safety signal in the 100, 500 to 1,000 people, we say we're going to go right into phase 3. And what phase 3 is, we call those the efficacy trials. And that's when we enroll in each of these vaccine studies that I'm going to talk about under Project Warp Speed. Will enroll at least 30,000 individuals, most of them across the United States. Some will be done internationally as well. And of those 30,000, some are going to get vaccine and some are going to get placebo. And depending on the trial, it'll be different. Some will be 15,000 get vaccine, 15,000 get placebo. Others, 20,000 will get vaccine and 10,000 will get placebo. And then we look to see how many cases of COVID occur during the trial. And we compare the number of cases in the people who got the placebo to the number of cases of the people who got the vaccine. And of course, what we're hoping is that there'll be very few cases in the group that got vaccine, and most of the cases will occur in the group that got placebo. So we're starting those trials very early on. I mean, generally, you'll wait a year or so till your phase 1 is published, then you'll start phase 2, and that'll take a couple years, and then you'll start phase 3, and that'll take 3 to 5 years before you've analyzed all of your results. Now we're just sort of compressing that timeline and really hoping that we're going to see some efficacy results in one or more of these vaccines before the end of 2020. And I also am cautiously optimistic that one or more of these vaccines will have enough data by the end of 2020 to know whether or not it works. The other question, though, is going to be, we're not going to have enough doses of vaccine for everybody in this country. And that's an entirely different issue. But
that was going to be my question, because I seen today where they saying you guys are going to need billions. I mean, billions of vaccines. And that's what I was going to ask. I mean, like you saying, I know they got the distribution set up and they got the manufacturers who they want to do that. But Anna, how do they distribute?
That's a great question.
Once it's done, how is it distributed then?
Well,
Is there choices? How does that work?
That is a great question. And I'm going to bring up something, else that is sort of, I think I don't want to say controversial, but something that is made clear during these trials. And that is, when we look at COVID-19, we know that there are populations who are more hardest hit by COVID than others, and particularly, populations of color. In Baltimore, where I work, the Latinx population, the African-American population has been incredibly hard hit. And some of those reasons have to do to generations of health inequities, systemic racism that has not allowed people to have the access to health care or be able to afford health care. And they're living with comorbid conditions like diabetes and high blood pressure that haven't been treated. And they've really been hardest hit by the vaccine. And when we ask people, when we've gone out, we've done community engagement to try to encourage people to volunteer for these studies, because we want to make sure that the vaccines are safe in these populations, in the elderly, in different, in the Latinx communities and communities of color. We want to make sure they're safe and they work. And what we hear from people is, if I volunteer for this trial, we've been left behind before. Are we going to be left behind when a vaccine is ready? How can we ensure that populations that have been hardest hit by COVID are going to be at the top of the list to get the vaccine? And there's a report out by the National Academies of Science about how to prioritize vaccination, CDC, and they are looking at that and trying to prioritize by risk group. In terms of who's going to get the vaccine first. But, and this is my opinion. I don't know if this is going to happen or not. But I said earlier, this is all of our tax dollars at work. It's my opinion. There should be a vaccine that is free to everyone, access to everyone. I'm sure, I'm looking around. I'm going to say we're all old enough. I hope I don't want to offend anyone, but we're all old enough to remember getting polio vaccine on a sugar cube. And we got that at school, and everybody went, and we didn't think about how that was going to be paid for. That was paid for through our tax dollars. And so, we're really working with communities to get engaged in these clinical trials, to feel invested in these clinical trials, and also to ensure that the vaccines are safe for the populations, but also so that they'll be available to these populations when a vaccine is licensed. And it is going to have to be prioritized. There are going to be tiers. There's going to be people at highest risk for severe COVID are going to get the vaccine first. Then there's going to be people who are at less risk, and probably last will be kids, because although, as Deb mentioned, we're seeing many more cases in people under 30, they're not hospitalized at the same rate. What they are, though, are they're spreaders. So they're the people, that's where the virus is being transmitted from that group of kids who feel really well, even though they have COVID. They're still going out and they're socializing and partying and things like that. But eventually, we're going to need to vaccinate everyone so that we can prevent COVID from coming back.
Huge job.
Yeah. And it's going to take, we are not going to have enough vaccines. No. I've heard predictions, by mid 2021. I don't think so. I think it's going to be, and then you think, we're exhibiting some, what we call vaccine nationalism here in the United States. And part of it is the federal government is paying for these trials and paying for production, but there are billions of people in the world. And we need to vaccinate everyone. We can't just vaccinate the United States because that's not going to do it. And so we also have to be thinking about how we're going to have vaccine for the rest of the world as well.
Well, I think a huge piece of this also, I think you just hit on it, is the population. Because when we were talking about this, I think the last time probably was maybe smallpox.
Oh,
we were trying to vaccinate the world against smallpox. I think we had half the world's population.
Yeah. I mean, it's crazy. And I think, I always like to give a shout out to Serum Institute in India, because nobody knows about Serum Institute. They make more than 70% of all vaccine doses given in the world today is made by Serum Institute of India. It's an amazing, amazing place. And they are committed to producing hundreds and hundreds of millions of doses of the vaccine, but they're working with one vaccine. So we have to hope that vaccine works, because as we say, they can lyophilize the state of Rhode Island. I mean, their manufacturing processes are incredible, and they make most of their doses of vaccine for the developing and underdeveloped countries that, can't afford the price of most vaccines. But again, that's one company. We have to build up companies in Brazil. We have to build up companies all over Africa in order to ensure that we're going to have enough doses of vaccine to really be able to control this. Okay,
Doc R is chomping at the bit.
I'm just sitting here telling you. These kinds of conversations, Doctor, are so important. That's why I love this platform on Sportsslaw, is because I think we reach a different audience. And it's so critically important for the public to understand that there are people like you and people in India and people all over this world that are putting their heart and soul into these types of problems, and governments are behind it. It's not anything but good, solid public health. And so that piece around vaccine acceptance and getting it distributed around the world is going to be critical, because, as you know, when you think back to smallpox, you're looking at, in a way it was easier because the geopolitical issues weren't quite as predominant as they are today. And now you've got those issues as well to deal with. Mm-hmm. And then I'm going to bring back up how critically important it's going to be while that's going on, as we keep building towards that promising future, is that I still think not just the U.S., but certainly the U.S. needs to really look at this as what next, what lessons are we learning? Mm-hmm. Face mask, people are still not completely on board with how masks can help. And I know they're not perfect. I'm a virologist. I'm a specialist in these areas. And I keep actually telling people, I understand that we're not all in an N95 mask and we're not all in respirators, but it still makes perfect sense to reduce, 40, 50, 60, 70% of the respiratory aerosols coming out of our breath, good hand hygiene, distancing. And as we talked about on an earlier show, I don't know if you want to comment on this. I talked about how 9/11 changed transportation forever, how this pandemic may very well change how we travel in a different way, not because we're worried about that issue, but that we're worried about who's sitting next to us, our physical space and things like that. So
absolutely. And I think what's really interesting, just in terms of epidemiology and public health, we're looking at now how COVID is affecting other diseases. So the flu season is coming up as an example, and people are very interested to see, are we going to have, how that's going to affect COVID, whether or not we're going to see fewer influenza cases because of the protective measures that we're doing with COVID, wearing masks, hand hygiene, social distancing. All of that also would reduce influenza. So I think that's an excellent point. And just moving forward, somebody said, is the handshake gone forever now? Other things that could change. If you travel in Asia, people wear masks all the time. And that's a result of SARS-1, which, didn't affect as many people, but really left an impression and a lasting effect in countries in Asia. And you wonder if we're going to see some of that now in the future as well. I mean, I want to come back to something you said, because Doc R, I think it was really, really important. You said vaccine acceptance, and that that is a hurdle that we have to really address and try to overcome. That is going to be a big hurdle.
Well, I think when we were talking before the show actually started, and Lomas, I think you can probably comment on this also. If athletes, this is sports law, so I got to go back to athletes. If athletes use their platform to say, we will take the vaccine, we will, I don't know, maybe be part of a phase 3 trial. We're willing to take this risk. Lomas, do you think that athletes will do that?
That's a great question. I think they probably would have to start with the organizations first, getting the organizations being acceptive of that, just like how we got these organizations now setting up their arenas as voting places now.
Right.
You know, they're going in on that movement. So I absolutely see this as a movement, just like the Black Lives Matter movement, just like the voters registration movement. This has to be almost like a movement, the coronavirus movement, where we got people influence directing people to, like you say, wear their masks. We see it with some of our coaches, college coaches and all that, but and they do have some doing it with the NBA and some of our superstars. But I just think with a combination of the organization saying, yeah, we're here, we're against COVID, and like I say, a joint effort, then yes, I can see guys coming. The only reason I'm saying that I think it has to be a joint effort is because it's so much, and going to sports, is so much untrust between owners and players. And they know that a player knows that if an owner had to use that against them in negotiation, they would flip that card in a heartbeat. And it's a bad card to flip, you know, COVID, concussions. They'll talk about that. If you had too many concussions, that's a reason why they want to get rid of you. So so that's why it has to be an acceptance with the organization and the players, I think, before the really, really work.
Wow, well, that's a whole other sports law.
Yeah. And Lomas, I want to say you brought up such an important point. It's all about trust. Everything is about trust, and we have to rebuild trust within our communities to get them to be receptive to participating in these trials. And part of it is they felt left out of previous research, or not just left out of previous research, but mistreated. And, you know, we go back to Tuskegee, which I don't think we have time in this podcast to go over that, and Henrietta Lacks and some other instances, you know, where they were truly mistreated and used. And we need to rebuild that trust, to have people feel comfortable and safe in our vaccine trials, and then have them as spokespeople, you know, help them spread the word within their communities, because they're far better spokespeople, certainly, than I would be in some of the different communities.
I have a question. We've got this B-roll going, and obviously right now we're looking at testing through a nasal swab. Is there a faster, better way of testing to either of my doctors?
Dr. R, do you want to start? Because I heard you say you're a testing guy.
Sure. Well, I mean, one of the crazy things right now with this particular agent is how many EUA approvals there are through the FDA. But yeah, there's definitely, they're looking at saliva. They're looking at what you just saw. There was more of a nasal nair kind of swab where it's not deep into your brain like they do with the nasopharyngeal swab. And so there's different methods. I mean, the RT-PCR method is the longest, takes the longest, a little more accurate with respect to sensitivity and specificity. And so while rapid testing is really critical, and Dr. Durbin talked about that earlier, and I totally agree with her, you know, from the lab standpoint, we also have to consider sensitivity and specificity. We've talked about that before, and we don't need to get into all the statistics about it, but it is critical to know the limitations of a test and the clinical limitations. And so it really is incumbent on the physician and healthcare team to kind of understand that, as well as the laboratory, and kind of work back and forth with that. Sometimes I worry a little bit about so many tests flooding the market that the general public may not understand that in a system where a negative test may not be negative, that kind of worries them, false negative.
Right.
That gets into the weeds a little bit. Certainly, we need to find a way to deal with what's an acceptable sensitivity and specificity area.
Yeah.
Lomas's dog.
Oh, I'm sorry.
I have a hound dog, Lomas,
Oh
luckily.
my God! I got about 100 pounds.
I have a schnauzer. We should bring in our dogs for the show.
I know.
We've got to do a dog show.
Yeah,
We've got to do a dog show.
We do. We do.
Yep.
So Doc, a big issue, doctors, a big issue was the false negatives that a lot of the players got. Do they, when they have tests, do they continuously try to make them better? Or how does that work? I'm just asking, how does that work? Because again, we had our quarterback, Matthew Stafford. I think he had like three false positives. Now, I know they said the NFL did say it was one particular lab that a lot of those came from, but do they continuously try to make those tests better? And like you say, Doc, how they're flooding the market with so many out there, how can we know if they're really, really accurate the way they should be?
Yeah, I mean, certainly I remember us talking about Matthew Stafford, and that was really unfortunate because I think it was 3 or 4 times that he was tested, and it kind of got nasty, right, on social media and things like that with his family. And
everything gets nasty on social media these days.
Yeah, unfortunately. So I mean, those types of things are really unfortunate, but that is always a concern, I think, and I know I'm sensitive to this because I'm a medical laboratory guy, and many of my colleagues will get very sensitive about testing, and there's no perfect test. I mean, there is no 100% test out there that's always perfect, but you certainly want to make sure that it's a FDA approved type of test, that it's coming from a legitimate source, that it's been put through the proper testing, just like you would for any other type of medical test, and then understanding the limitations of it. Sometimes it might be a better screen test, which means you might be able to use it to look at, if they're truly positive, they're positive. If they're negative, you might have to follow it up with a confirmatory test or something like that. So it's really incumbent upon the professionals to make sure that those tests are being done correctly and being implemented correctly. The only concern I have, and this is always a concern, are there tests out there, which is kind of another topic, but are there tests out there that are being run at different areas that just aren't legitimate? People taking advantage of people in a way that we've seen before in other types of medical areas. So, that's kind of a regulatory issue that we need to watch out for. But otherwise, if it's a typical test that you see that's EUA or FDA approved, it should be fine. Yeah. But again, you want to consult with your doctor and with others that are running those tests.
Yeah. I want to go back to access. I'm sorry, Anna.
No, go ahead. Go ahead.
I just was thinking about access to tests, because right now what we have is the athletes, every team, they're fully tested. Mm-hmm. But our producer, if he feels bad, he hasn't been tested. Not everybody can get a test.
Or if you get a test, you have to wait 2 weeks for the result. And that's
right. By that time,
not helpful. That's not helpful. Right.
No.
Yeah. I mean, this goes back, in my mind, this goes back to the national strategy issue.
Yes.
We still need to figure this out. It's frustrating. Yeah. I mean, it can be done. It's just decisions need to be made at a level where people get in line and they know what the rules and regulations are around testing. There is no reason other countries aren't doing this. It's not taking 4 weeks to get a result. That's ridiculous. Contact tracing shot to, if it's more than 72 hours, really less than that. So we need to figure it out. It's ridiculous that it's taking that long to get a result. In the United States of America, we should have a result within at least a couple days, in my opinion.
Absolutely. Yeah. Absolutely.
I think I was reading something that said that prior to the pandemic, they said the United States was the #1 country to be able to handle a pandemic. And I would say that we certainly have failed on that one.
Well, we did disband our pandemic preparedness task force.
Yes, we did.
And we don't participate. We don't participate in WHO anymore. I mean, there's so many issues in the public health sector that just drive us crazy in healthcare and public health. But it's a shame, and sometimes it's very frustrating. And so I just try to keep plowing ahead. Today, when I was listening to Dr. Fauci, what an inspirational man. You talk about RBG and I mean, I consider him just like Dr. Durbin. People that are working in these areas, it's almost like the country and the world needs to realize that individuals doing this work are actually heroes in a sense. I mean, they're working their butts off every day of the year, every day of the week, and every hour of the night. Dr. Fauci brought up how he was working, 20-hour days, and his wife made him get 5 to 6 hours a night. And a question came to him about burnout. We talked about mental health, and the interviewer asked him, what about you and your family? Is anybody thinking about you? And he said, my wife is thinking about us and helping us take care of each other. But he said, burnout's not an option. I mean, he just said, when I lay down at night, my brain won't stop. There's so much to do. And he said, I know it's not the right mental health answer. He said, it's not an option. We have to learn these lessons. We have to move forward, and we have to solve problems. And I think a lot of us feel that way. I feel like I haven't stopped since January in so many ways. But, every day you just get up and you keep moving forward and hoping the next one's going to be better.
Well, let's ask that question. Everybody's burnt out. We are all so tired of this. I see people starting to go out and they're starting to not wear masks, and they're saying, oh, we're getting back to normal. We're getting back to normal. I get to go bowling. I get to go watch the football game. I get to do things. We're all tired of it. So how are the three of you doing? Anna, how are you doing with this?
I'm busier than ever. And I think what does, when this happened, and part of it is being an infectious diseases physician, the first thing you want to do is you want to be in the action. You want to be there, and you want to do what you can, and you want to treat patients if you can treat patients. You want to feel like you're doing something. And I think part of the whole, we don't have the 7 stages of grief or whatever. We don't have, but I think, tell me if you guys can relate to this. So at the beginning, right, people want to do something. It's like after 9/11, you want to do something, right? This is a crisis. Just saying sit at home and don't leave, that almost from a mental health perspective, I think was harder on so many people. At least, I felt like I was doing something. I could go to work. I was doing drug trials, and then I got involved in vaccine studies. And it is very busy, very busy. I will tell you, I try to exercise that at least to clear my brain for a little bit, but we know, and this is what I keep saying over and this has never happened in my lifetime before. Something to this scale. This is surreal. This has never happened to us before. And you have to think, what are we going to do? How are we? And I wish more people thought, how are we going to get out of this? We're going to get out of this. We would have gotten out of this, or at least had things, I think, much more under control with far fewer deaths than 200,000 if people would do simple things like wear a mask, wash your hands, social distance, and hopefully when a vaccine becomes available, take a vaccine. The only way we're going to get out of this is if, people think of the greater good of society, think, not of yourself, but how are you going to protect the people you love? And, I think it's easier in some respects for me because I can, as I said, focus my work on trying to help us as a country, as a world, get through this. And it is hard work. It's a lot of hard work, but I have supportive family and great people I work with, and I see progress being made. There's a lot of frustrating. There is a ton of bureaucracy that drives me absolutely crazy. A lot of it at my own institution and the number of committees I have to go through when I'm, and this is what I say to them. this is unprecedented. We need to do things differently. Right.
Good point.
Yeah,
Good point.
this is a bad situation. We can't do the same old, and that stuff drives me crazy. But, that sort of, I feel lucky in that I can work directly with it. And I'm interested in how all you guys feel too, because I think, friends that I talked to, as I said early on, just wanted to do something and there was nothing they could do. And that was almost more frustrating.
Yeah. Doc R, what do you think? How are you doing? I mean, I know you two are just, everybody here is working on this constantly.
Yeah, I'm doing okay. I'm doing better than I was in the summer. I felt like I was just burning it up. But, interestingly, as Dr. Durbin mentions, the most productive time of my career. I can't believe what a person can get done under these circumstances, but it does wear on you. And so I do some of the similar things. I have a wonderful family, very supportive, and colleagues, but I also exercise. That's really helpful for me. And try to turn off the TV and the computer occasionally. Even though I live with it, I do try to make myself follow my own rules of kind of just turning off some of the information overload that really weighs on people, I think. But yeah, having something to do helps. It certainly, as a person in the lab and has done research with other international projects like rabies and stuff, it's engaging in a weird way. I mean, you want to be in the action, you want to get in the trenches and get going. And so that's, in a weird way, it's kind of exciting and not that I'm excited about a pandemic, but just a new agent and a new thing to study and learn about. But then, then the fatigue sets in and you have to kind of start thinking of ways to deal with that and learning how to say no. As the doctor said, I mean, I can't even tell you how many committees I sit on at the academic level and professionally. So it's any meeting over an hour is just ridiculous in my mind. But
well, we're really thrilled that you always say yes to us.
Yeah.
This is fun.
Right?
Yeah. Lomas, what about you? How are you doing?
Well, busy now that the season has started, and my whole world has been turned upside down by not being able to travel, calling games through a monitor instead of being able to watch, be there in real life to watch away games. That's just been different. And I just think the industry, the media industry, it's just turned, on this axis. It's just, they didn't expect this. And I don't know, doctors, I think it might be a good thing for them because of the revenue that they're saving. They don't have to, talent doesn't have to travel. They're doing everything virtual. They got more eyeballs probably on the TV and on their networks now than they've ever had before because people can't actually go to the sporting event. So I'm interested in this just to see how this is going to play out in the future. Dale, what about you?
Well, I'm actually, I found out that I'd be really good under house arrest because I'm loving working at home.
That's pretty good.
I am finding that because I'm doing things like this, I feel like I'm doing something because somebody like me, I'm a lawyer, I'm a prof, I run a business. I'm not front lines. And I kick myself, Ann and I took AP Bio together. I kick myself sometimes at a time like this saying I should have been a doctor, then I'd be on the front lines and I could do something. But this is what I can do. This is what I try to do is get the word out, talk to the kids. Sometimes it's about mental health and learn as much as I possibly can. And, and it's really fascinating to see how the world is changing. It really is. From the broadcast standpoint, it's kind of back to the future. I mean, Ronald Reagan started as a radio broadcaster where he wasn't there. He was relying on the, teletype basically.
Right.
Or fax machines. And to see how far we've come in medicine. I mean, wow. We didn't, like we talk about the different vaccines and the, RNA and DNA and the things, mRNA, I don't think that existed or we even knew it existed back in 1978 or anything like that. So there's so much. And
so much.
I I'm heartbroken over everything that's happened, and I'm excited about what will happen and how we're changing. And to a large extent, some of it's for the better, I think.
Yeah, it'll be interesting. It will, I think, to Doc R's point about travel and how that, what will that look like in the future? I mean, I do think, and this is from a teaching standpoint, because I teach at the School of Public Health and also in work meetings, I do find limitations to Zoom. Like you don't have that connection. You don't have that connection with your students. I think it's less productive to do collaborative work. And it's really fun to, go and work with colleagues in Brazil or in Taiwan or, Vietnam and see that. So it'll be interesting to see how that changes. But we definitely don't need to do as much travel, I think, as we used to do. I mean, certainly things that have evolved around Zoom and technologies to allow collaborations and collaborative meetings has had a lot in just a short period of time. And I think this is going to continue to evolve.
It's amazing how far we've come. And I am being told by our producer that we are out of time.
Oh, that's what
this was so fun.
I
know. This is fun. We got to do it again. We're going to have to do it again. I think we touched on about this much of it.
Yeah.
And I do want to tell Lomas, though, I root for the Lions every Sunday. Every Sunday I do. We don't get them in Baltimore, though. I didn't, and which upsets me. But I wish I could, because I do. I love the Lions.
Yeah, you're saving yourself some pain and some misery. You are saving yourself a little pain and misery. But I understand, true Lion fans, they're with them through thick and thin. You're right.
Okay, well, thank you, everybody.
Thank you, guys.
Yes.
And for all of our listeners, check us out on sportslaw.com, on Facebook. Send us some of your questions and give us some ideas on topics you want to talk about. But thank you, Doc R. Thank you, Doc D.
I like
Thanks,
that.
Dad Lomas and Doc R. It was great to see you guys.
Absolutely.
Bye-bye.
Take care.